speak, I know just what you're saying. So please stop explaining. Don't tell me 'cause it hurts. Don't speak, I know just what you're thinking. And I don't need your reasons. Don't tell me 'cause it hurts.
Good morning, everybody. Welcome to the final day of this year's World Congress. And we're going to have a very interesting session here talking about the metabolically challenged patients and the consensus project that we worked on over the course of the year. So if I can get that aims and status slide up. So this is the IFSO's consensus conference that we had in Hamburg earlier this year, and I'm going to just kick it off and talk a little bit about what was the aim and what's the status of the project. My connections with industry have no bearing on this presentation. So obesity, as you know, is a challenging, incurable disease, made more complicated by the fact that our patients are viewed poorly by society, humiliated, tortured, and denied access to health care in some cases. And for our treatments to be better, we've determined that we need a multidisciplinary approach, and we also need to change the terminology to make it less offensive to our patients. And that's basically what we did here. So we met in Hamburg for 2 days and had a long meeting. As you can see, we had a diverse group of participants, mainly surgeons, but also other disciplines as well. We had 44 international experts give presentations at the meeting and then take questions and answers. We then performed what's called a modified Delphi study, which I'll explain a little bit to you in a moment, where we had the experts provide either questions or statements, and we collected 138 that covered pretty much the field. We then went and took votes on this. We had actually 3 rounds of votes to see which ones we agreed on, which ones we may not have agreed on, and anyone that had greater than 70% consensus, meaning that we all agreed or we all disagreed with it, that then became one of the points that we approved from the meeting. And we did that for all 138 questions. We also spent quite a bit of time wordsmithing new titles for the disease and for our patients that are not humiliating or upsetting for them, so that it would be a more reasonable way of communicating not only to patients but to colleagues about the disease and the patients. And this is what a couple of the questions look like. For instance, I'll look at the lower one. All patients with severe obesity, BMI greater than 50, should have a preoperative cardiac evaluation. If you agreed with that, you voted yes. If you disagreed, you voted no. And then we went to see where the majority was and did we reach a 70% consensus. We also looked at ways of defining what we thought to be the consensus best, say, diet, exercise program, types of patients to undergo surgery, and you'll hear a fair bit of that during this session. New terminology that, like I said, was less offensive to this group. And what's the status of it? The book's out today. So if you want it, just go to the IFSO booth and you can get your copy there. So without any further ado, I want to invite up the next speaker,
which will be Pauliina Salminen from Finland. She's the incoming president of the IFSO European chapter, and her topic will be very important, the standardized reporting and definitions. As you know, in the past, we didn't give numbers to certain definitions, and also the language terminology was changed, which is a very, very important part of that IFSO consensus conference we had in Hamburg. Paulina, please.
Thank you very much, and good morning to everybody. Scott nicely outlined, can I have the presentation? Thank you. So Scott very nicely outlined the whole process, and my job for the first talk is to go over the definitions, because honestly, as we had it in modules, so this was module number 1, and this was a bit different from every other module, because for this one, we did want to have consensus on each and every one of the statements. The idea of this group effort of multidisciplinary experts from all over the world was to have a language that doesn't have any negative connotations for the patients, so avoiding stigmatization, and again, to have a language and terminology that would be applicable also within outside surgical field, so the whole medical community. My disclosures, nothing relevant for this talk. Like Scott said, we had 136 statements, and there are 15 on the definitions, and really the wordsmithing, I think, was applicable to module number 1, because we did a lot of rewording of the initial statements and had very many discussions on all of the topics to have an agreement on all the 15. And I think the very strong point in the whole consensus was that we did have a multidisciplinary group, so it was really a group effort of all subspecialties. And I think to have the similar terminology, that we're actually discussing about same things, so we're not comparing apples and oranges when you look at different papers. So for example, for suboptimal initial response or the later recurrent weight gain. So really, we have to look at that we are discussing similar issues to have comparability of different trials. So now I will just briefly go over the statements, but first, this is the module. Like I said, we had an agreement on all of the 15 definitional statements and reporting standards, and with a mean level of consensus of 90.1%. And just for the comparison, for the metabolic bariatric surgery statements, it was 80% of the statements that we reached consensus on, with the mean consensus level of 79.6. There were 13 reporting definitions and 2 reporting standards. And no, I have to go back one more, because I have to, at this point, acknowledge the module 1 we were working with Gerhard, but I would really like to stress the importance of Lee Kaplan on the definitional statements. His participation was invaluable, so that's why the slide is here. So going over to the actual statements is the initial one, like, of course, everybody knows that we've banned the word failure. You can't say that. That's a no-no word. But you really can also, insufficient has a negative connotation. So really, we're aiming for something that would be very neutral. So the 100% consensus was reached on having a suboptimal initial response to metabolic and bariatric surgery. And I would like to stress, even though weight loss is the key driving force of all positive outcomes for metabolic bariatric surgery, we did add it's either inadequate weight loss or an unusually modest improvement of the significant obesity complications. So it's either or. And then again, a late postoperative clinical deterioration, it's either also demonstrated by recurrent weight gain or by worsening of the significant obesity complication that was initially one of the reasons to proceed with surgery. And like you see, we did discuss on the number 3 is more of a general statement, to agree with the clinical response to metabolic bariatric surgery. Suboptimal, of course, has to be evaluated patient by patient. There, you really can't have a strict categorization there. So the severity of the suboptimal response should guide clinical treatment. And I would again stress out that we're aiming for definitions that would be applicable to the whole medical community. Then we did, moving on to more specifics on the weight. So as we all know, when you look at different studies, the baseline weight is reported very differently, which of course, again, is a major issue in comparing the different studies. So the baseline weight for assessing weight loss after metabolic bariatric surgery should be the weight that is before starting preoperative weight reduction, as the surgical procedure is the one that actually makes the weight loss sustainable. So not on the day of surgery, but when you actually start, because without the surgery, following that preoperative weight reduction, the weight loss would not be sustainable. So this is we're really, with these statements, we were aiming to address the idea that we are able to assess the effect of the surgical weight loss. Because of course we now have, which is great, hopefully AOMs, the new anti-obesity medications, will increase access to surgery, because we all know that access to surgery is way too low. But we did want to have these definitions so we're able to assess the magnitude of the surgical weight loss and then something else. So this is why number 5 and 6 are associated with the anti-obesity use associated with surgery. So if you have it before but you stop it after, the baseline weight is determined before the anti-obesity medication was started. So this would allow us to assess the effect of anti-obesity medications and then just surgery. And again, if you continue it, it would be the day of surgery if you continue the AOMs after surgery. And the initial surgical weight loss, and that would be the maximum weight loss within the first 2 years, it should be determined in a way that excludes any post-plateau weight loss caused by adding any other intervention, if it's medications, an endoscopic intervention, or dietary issues. Moving forward to the revisional and conversion surgery, because again, the terminology used for these in the literature is very variable. So the idea is that conversion surgery would be that you are actually introducing an additional mechanism to the therapeutic action. That's a conversion. For example, converting a sleeve gastrectomy to a Roux-en-Y gastric bypass would be a conversion. And then revision or modification surgery is actually you're trying to optimize the initial surgical procedure, so the effectiveness of the previous operation, you're trying to enhance or optimize that. And this would be crucial to have this terminology correct, so we're actually discussing about the same issues. Then going over to, we did decide to use obesity complication, and this was very, as you can see, the consensus level is 80.5, so one of the lowest we had. So instead of discussing just comorbidities, and this is based on the fact that we wanted to stress the fact that if we know the causative action on if there is a causation with obesity and the actual published evidence on this relationship and association. Otherwise, it's going to be an obesity comorbidity. And then again, for the effect of metabolic bariatric surgery on the effects, so micronutrients and macronutrients need to be really clearly distinguished. Then going over to the characterization, because of course everybody knows that we're far away from the previous ideas that we have a restriction and malabsorption. Malabsorption is negative, that's not what we want to have. So you really need to be using the terminology to characterize the effects of the metabolic bariatric surgery more in the line of the anatomical features, instead of aiming to assess that these are the the mechanisms of action behind the procedures, as we know that this really is it's not that simple. So this was, again, as you see, very high consensus level, but this was also very thoroughly discussed. So rather anatomical features than aiming to imply that the mechanisms are behind that. And then to conclude, we had the 2 reporting standards, and this was again very thoroughly discussed because it's very difficult to have categorization of the outcome with just one. So if you have like 19% total body weight loss, or then you have like 21 and the other one is bad, the other one is good. But we did want to reach the number in order to actually kind of help assess the literature that we have. So we would have like some kind of a common indication perhaps to enhance the treatment for the chronic disease of obesity. So suboptimal initial clinical response, the limit was set at 20%, and for the recurrent weight gain, which is the terminology to be used for the postoperative weight gain, is if it was more than 30% of the initial surgical weight loss. And again, not just weight loss, but for the both statements, also the obesity complications. It's either or. And as you can see, the consensus percentages are a bit lower, but we did reach that. So thank you very much. This was a tough job, I think, also for the whole expert group, but I'm so happy that we were able to do it. Thank you very much.
Thank you very much, Pauline. I think this was a great piece of work, and it's a lot of information that comes to you within a very short time. You really need to read that. I think it takes some time. Are there any questions? We have time for 1 or 2 questions.
And even though it said unpublished, the book now is out. It looks very good, but the paper is now under peer review, so it will be hopefully published in our journal.
If I can just add and acknowledge Paulina for the amount of work she put into this. We all worked very hard for the entire process, but she in particular worked extremely hard and was very passionate about redefining these procedures and these diseases.
Thank you so much.
Please. Can we activate the microphone in front?
Hello. It's Surendra Ugale from India. The question I have for you is this. You mentioned in one of the points that you take the preoperative weight as the one, especially those who had the medication and stopped it. So you want to take it as before the medication?
No, the weight, if you have it before surgery, you should have the baseline weight before you start the AOM. And that's one tricky because sometimes you may have a patient that comes in for a consultation that's already before, so before that. But these 2 statements were specifically put in there so we would be able to differentiate between the effect of surgery and the effect of the AOMs. And of course, it's not a perfect solution, but that's what we came up with.
Because I thought that wouldn't the others accuse us surgeons of trying to cheat over there and utilize the leverage of the AOM?
Yeah, but that's to differentiate the effects. Thank you.
Thank you, Paulina.
Thank you very much.
It is my pleasure to invite our next speaker who will speak on diet, lifestyle, and exercise. Silvia Lete Faria from Brazil, who is the incoming president of the Integrated Health for IFSO.
Good morning, everyone. I'm glad to be here. My name is Silvia. I'm here from my behalf and also from behalf of my group of experts, Dr. Barbara, Dr. Violeta Moise, Dr. Dale Bond, and Dave DeSalver. Well, my module means that diet, lifestyle, and exercise matters for treating obesity. So next, please. I guess I have it. Okay, I have nothing to disclose. Well, patients that are being treated for obesity or had a metabolic and bariatric surgery should adhere continually to a rigorous, integrated, interdisciplinary, and patient-centered program to achieve success. And healthcare professionals are needed in different areas: nutrition, psychology, physical activity, and lifestyle modification. The main objective is to prevent, identify, and manage the risk of short-term and long-term complications, possible complications after metabolic and bariatric surgery. So we had 5 experts participating. So I will summarize the main points from each area. So in terms of nutrition, we know that we have different procedures, and we had 2 main points. First is our concern in terms of macronutrients, and we are just concerned about protein intake due to decreased ingestion and also decreased contact with food enzymes. In terms of micronutrients, we are concerned about vitamins and minerals, due to also decreased caloric intake and also decreased contact with food enzymes, altered sites of absorptions. So, summarizing, nutritional multivitamin supplementation is a cornerstone for patients' quality of life. And so to prevent that, we need a multivitamin, the adherence to multivitamins, and to prevent protein malnutrition, we focus on adequate protein consumption. The main point for that, the objective is to prevent sarcopenia, to prevent the decrease in muscle mass that can lead to decreased basal metabolic rate and can expose patients to rate recurrence. Procedures that have a hypoabsorptive component will need greater demand of protein and liposoluble vitamins. In terms of lifestyle modifications and psychology, we know that, this is a point that erased, education to guide patients' dietary practice, physical activity, and lifestyle behaviors should be provided both prior and after metabolic and bariatric surgery. Patients must have access to specialists in metabolic and bariatric surgery or experts that know how to treat complex obesity. Experts should transfer skills to the patients. Studies support the use of acceptance-based behavioral treatment as an aid for metabolic and bariatric surgery. It means that we are going to focus on the good side of the treatment and go a directed guidance in line with patients' values. Telemedicine and apps are additional innovations currently being suggested. So in terms of physical activity, it should be stimulated starting from the preoperative stage. It leads to mental health improvement. It's just not just like burning calories, and also favors lean body mass preservation during weight loss. So, and besides that, physical activity will confer numerous health benefits in metabolic and bariatric surgery patients, and it comes from observational and experimental studies. So, after all of the points that the experts have summarized, we had the results. We will see this in the book. So I will summarize that. So in terms of nutrition, there was a consensus that the minimal amount of protein for metabolic and bariatric surgery patients is 60 grams per day. And patients that are submitted to procedures that have a hypoabsorptive component will need a higher quantity, like 80 to 100 grams per day. A rehabilitation program considering protein intake with strength training should be prescribed for patients that are over 55. Sarcopenia should be studied among this population. Increasing physical activity has clinically significant benefits for this population. Individuals need some form of behavioral intervention to modify physical activity and sedentary behavior should be, it is needed before and after metabolic and bariatric surgery. Most individuals who engage in the low level of moderate to vigorous intensity physical activity and have high levels of sedentary time before surgery make only modest improvements in this during the initial years after metabolic and bariatric surgery. We also agree that all patients with a known or suspected mental health diagnosis should be undergoing an assessment with a mental health professional, whether prior to metabolic and bariatric surgery, whether they are being treated or not. And we couldn't reach a consensus that every patient should undergo an assessment with a mental health professional prior to metabolic and bariatric surgery. So in conclusion, healthcare professionals specialized in metabolic and bariatric surgery are essential for the treatment, and further studies that continual research for surgical and non-surgical solutions may contribute to the successful long-term outcomes for patients who have undergone metabolic and bariatric surgery. Thank you.
The next topic is the medical treatment of obesity. Unfortunately, Dr. Rachel Batterham was not able to be here to give the talk, but Dr. Alice Minos has volunteered to give it for her. So thank you very much, Alex.
Pleasure. Thank you very much for asking me. So, can I have the slides, please? Good. So, pharmacological treatments for obesity. What I'll be doing is I'll be going through the main points that I would like you to take away from this, the highlights of our discussions. These are my disclosures. Okay, so statement one, weight management should not be restricted to a stepwise approach, but be tailored to an individual's health status. This is all in line with personalization of obesity care. The reason why we're saying that is because now we understand more about the amount of weight loss that people need to lose in order to improve obesity-related complications. So you will know that mild hyperglycemia, for example, pre-diabetes, even 5% weight loss will be enough to improve this specific complication of obesity. But when it comes to more resistant complications like, for example, cardiovascular disease, we need double-digit weight loss, which is likely to be more than 10, probably more than 15% in order to improve the specific complication of the patient who's sitting in front of us. Therefore, certainly considering what the patient has done before, it is highly unlikely, for example, that with lifestyle modification we're going to achieve that. Not impossible, but highly unlikely. And therefore, for that specific patient, you might want to start to be thinking early about pharmacotherapy or surgery. Another statement, which is very important, is that response to weight management should be reviewed frequently and altered in a very agile manner if there is a suboptimal response or additional weight loss is required. Why? Because we know, first of all, that there is a very large heterogeneity in the responses to any treatment we provide for obesity. And it spans across endoscopic, lifestyle, pharmacological, and surgical therapies. So if, for example, someone has had a suboptimal response for their specific obesity-related complication with a medication, then we need to be very agile and start to think about surgery very, very rapidly rather than waiting and waiting and waiting, because by waiting, nothing much is going to change. By repeating things, not much is going to change, and we're delaying care. The most important point to make an initial assessment of the response to treatment is 3 to 4 months after surgery, after medications, after surgery as well, but in this case, medications. It is critical because if the patient has responded in the first 3 to 4 months, they will continue to respond for the next 3 years and beyond. If they have not responded for the first 3 months, they will not respond over the next 3 years, and that is the point where you need to be agile and change or add a treatment. Third statement of importance, that obesity pharmacotherapy and medications are appropriate for long-term use in people over the age of 12 for the treatment of obesity. So they are appropriate. There are 2 points that I would like you to stress to see on this statement and stress on. The first one is the long-term nature of the treatment, and the other one is that obesity pharmacotherapy or specific obesity pharmacotherapies can be given to even young adults over the age of 12 in some countries. Why is this a long-term treatment? These are data from the STEP 5 study, in which semaglutide was given versus placebo in adult patients with obesity. And what you'll see there, which is where the line is this is where the medication was actually stopped. And what you will notice is that there is a very, very rapid weight regain because this is a biological treatment for obesity, which only works when people are taking it, and it stops working when people are not. The second point, which was about adolescents, comes from a number of randomized controlled clinical trials that have shown that specific obesity pharmacotherapy can be very effective in adolescents in a safe manner. And what is very interesting, and what you will notice both in terms of liraglutide and here semaglutide in the STEP teen study, is that the amount of weight that the adolescents lose is exactly the same as adults. And it is approximately 16% of total body weight loss. So a number of countries around the world will have licensed some of these medications for use after the age of 12. A lot has changed in our understanding of what we call genetic obesity, and here we are mainly focusing on monogenic causes of obesity. For example, melanocortin-4 receptor deficiencies, etc. And I will tell you more about that in a sec. So if available, genetic screening for monogenic obesity and syndromic obesity should be performed in people with a body mass index over 40, but even more importantly, a history of childhood onset obesity, usually before even the age of 5, and hyperphagia, excessive eating, which affects someone's daily life. And in some countries, setmelanotide, which is an MC4R, melanocortin-4 receptor agonist, is available and should be offered to children over the age of 6 even, who have got a genetic mutation or syndromic obesity in accordance with its licensed indications. The data from that comes from some very good randomized controlled clinical trials. Here you'll see very impressive weight losses in people who have got these very, very uncommon POMC and leptin receptor deficiencies. You will be very, I think, pleased to hear that we are suggesting that adjuvant obesity pharmacotherapy should be offered to both adults and children who require additional support and treatment even after metabolic or bariatric surgery. And I hope that you had been able to enjoy the lectures that were given during this meeting on the 2 randomized controlled clinical trials supporting the use of liraglutide, 1.8 milligrams in people who have had a sleeve gastrectomy or gastric bypass for diabetes, and also the latest evidence on the use of liraglutide, 3 milligrams, to people that have not lost enough weight after the same procedures. And it is important to note that these medications work exactly as well as in people who have never been operated before. So in conclusion, there has been a fundamental shift in the way obesity is treated over the last few years, and I'm really pleased that the language that is being used in these guidelines is very disruptive, and it is very much up to date with the latest scientific understanding in the field, and it will also allow us to align with other international organizations that are non-surgical in nature. The guidelines provide a new framework of thinking differently about the disease and highlights a lot of its biological drivers. And the consensus group consisted of a wide range of professionals, not just surgeons, and I think overall this effort is going to have a major impact. Thank you very much.
Thank you very much, Alex, for wrapping up this extremely important topic. We have time for one short question. What can you expect in the monogenetic causes using setmelanotide? What is the amount of weight loss you would expect?
Yeah, that is very interesting. What is particularly interesting is that what we always thought is that if you have one target, one target that's causing the problem for obesity, i.e. one gene deficiency, if you treat that, you're going to fix the problem and get the same result in all patients. So we thought this was the most personalized treatment we have for obesity, but what you'll see is that there is still variation even after this treatment. But for people who have got this very uncommon deficiency called POMC deficiency, which is one of the signaling nuclei in the hypothalamus, the people will lose about 25% of their body weight, so effects similar to surgery. People who have got the leptin receptor deficiency, again, part of the signaling in the hypothalamus, are going to lose less weight. We don't understand why that is. But we're talking about major weight losses here.
Thank you very much. We have to go on in the program. It's my pleasure to announce our next speaker, Christine Stier from Germany. She's heavily involved in the endoscopic treatment of obesity, and her talk will be exactly on that topic in the light of the consensus conference. Please, Christine.
Thank you, Gerhard. Thank you, everybody. Good morning, everybody. It's my pleasure to lead you through the statements that were consented and did not reach the consent regarding endoscopic treatment, and different to medication, endoscopic interventions act via the mechanoreceptors of the stomach and only have secondarily metabolic effects. This does not work. These are my disclosures. They have nothing to do with the talk here. So you know that we had the consensus in March in Hamburg. This is another picture of all the experts that were involved. And you heard already that there were 34 persons who did the consensus conference as the experts. There were only 4 endoscopists, who was Barham Abudayev from the US, and Chris Thompson from the US, Mohit Bhandari from India, and me from Germany. There were 3 presentations on the topic regarding the 1B level evidence that was created with the MERIT trial published in the Lancet last year. It was on endoscopic treatment in adolescents, which I presented and looked up the evidence that was available, and was the topic of Chris Thompson, who presented on endoscopic treatments for metabolic changing patients. From this evidence, we created the statements that then had to be approved. So the results of the process regarding the ESG I want to present you, and I ordered it in a way so that you can get it easily in mind. First of all, indication range with respect to the obesity classes. So there was consent on the statement that ESG combined with lifestyle intervention is preferable to lifestyle intervention alone for the management of adults in class 1 obesity. Remember, there is 1B evidence for that published with the Merit trial. It is exactly the same for class 2 obesity. Again, 1B evidence, Merit trial published in the Lancet last year. Then we consented and agreed on the statement that ESG combined with lifestyle intervention is an acceptable management option for adults with class 3 obesity who are not eligible for surgery for whatever reason. We had to prove the evidence for durability of ESG. And we consented, because there was evidence out for a time range of 12 to 24 months, we consented that durability of this intervention is for 12 to 24 months in follow-up. The next statement was the comparison of ESG to non-invasive therapies, and there were more possibilities to answer. And there was consent that individuals with class 1 obesity and comorbidities, ESG is superior to lifestyle changes. There was no consent that it is superior to medication, and no consent that it's superior to both of that. But it is superior to lifestyle intervention. So the next thing is really a project of my heart, and I think it's a milestone in obesity treatment. This is the indication for the application of ESG in adolescent. And as you can see, there was consent on the statement that ESG combined with lifestyle intervention is preferable to lifestyle intervention alone for the management of adolescents with class 2 obesity. So the next statement was that in individuals with class 1 obesity and comorbidity, ESG is not suitable if an individual does not want surgical treatment. That means if an individual does not want an invasive treatment, you cannot recommend ESG. We also consented on this. So what were the points? There was no consensus reached. There was no consensus reached in the treatment, in the superiority of ESG over lifestyle in class 1 obesity and in adolescents. And I think that this is a future project, or must be a future project, how these patients could be treated in a definitive pathway. Interestingly, there was no consent on the use of intragastric balloons at all, nor in class 1 or class 2 obesity in adults, neither in class 1 or class 2 obesity of adolescents. The criteria in adolescents was because of the possible hyperphagia component in those patients, but there was also no consent in adults. There was no consent of the use of IGB in class 3 obesity as well. So you see, this states for me that it was consented that ESG is a superior treatment over IGB as an endoscopic intervention. You all heard that this is taken together in the IFSO book. So let me conclude. The experts consented that ESG is over lifestyle, but plus lifestyle in obesity class 1 and 2. It can be used in obesity class 3 in adults that are not eligible for surgery. And it is consented that this is a very good treatment for adolescents with class 2 obesity. There was no consent For the intragastric balloons, there was no consent for the use of ESG, endoscopic sleeve gastroplasty, in adolescents with class 1 obesity. And I just wanted to point out that there was a comparable consensus as a joint project of IFSO and the World Gastroenterology Organization that is published already, only to let you know that this consensus is really a global one. And with that, I want to thank you for your kind attention. We really worked a lot, we considered a lot, we discussed a lot, but I think we really did achieve a lot. Thank you very much.
Thank you very much. We don't have any time for questions. We're a little bit behind, and we're going to try to stay on schedule. So I'd like to invite up the next speaker. It's an honor and a privilege for me to do so. Dr. Lillian Cow, who was front and center with this entire project, and she's going to talk about the surgical treatment of obesity, procedure choice, and algorithm for primary procedures.
Good morning, everyone. It's my pleasure to talk to you about the surgical treatment of obesity, which we discussed in Hamburg over 2 days, and I'm going to take you through what we did over the couple of days and what we came up with as a consensus. This is my case mix disclosure. As you know, I come from Australia, and I started with a gastric band practice that has moved on to sleeve gastrectomies and gastric bypasses. As far as this session is concerned, I have no potential conflict of interest to report. So in our discussion, we went through a huge number of statements. We had 43 attendees, of which 26 were surgeons. We went through a preoperative decision-making. We looked at the indications, contraindications, specifics of each procedure, and comparisons between procedures. There was a lot to discuss. So this is a framework of how we work through our discussion, starting with endoscopy and then working towards the types of surgery. So let's start with endoscopy. We felt that pre-operative endoscopy is a must for metabolic and bariatric surgery, and we have level 1 evidence that severe gastric disease, esophagitis, Barrett's esophagus exists in asymptomatic patients. This is a study that looked at this. This is a systematic review and a meta-analysis of 59 studies, over 32,000 patients, and what they found was the overall incidence of pathology was higher than expected, and even higher in the preoperative group that had the endoscopy. We also looked at H. pylori, because we felt that H. pylori must be evaluated because it can be a precursor to gastric cancers, atrophy, ulceration, or GIST, and it should be eradicated because there is a risk of gastric cancers in the long term. This is just a quick slide to show you that this is looking at risk factors for stomach cancers, and you can see that in the red, which are risk factors, and Helicobacter infection rated fairly high on the association with gastric cancers. If you eradicate H. pylori, this study shows that by eradicating H. pylori, you do decrease the rate of metachronous gastric cancer by 50%. We also had a discussion on Barrett's esophagus. It has increased prevalence after sleeve gastrectomy. This increases year by year, but not with a Roux-en-Y gastric bypass. And we also had a discussion on hiatus hernia and reflux. We also had a discussion about sleeves and bypasses, and this was well presented by Paulina and Rubino. This is Paulina's study showing that after sleeve gastrectomy at 10 years, there's a higher incidence of esophagitis. So what are the types of operation we're going to give these patients? Well, we know from our global registry that was published this week, sleeve gastrectomy remains the most common operation worldwide, followed by Roux-en-Y gastric bypass, followed by one anastomosis gastric bypass. And this is based on 26 national and regional registries. We had a nice discussion, and this was presented by Francesco Rubino about the mechanistic studies on humans comparing type 2 diabetes, and this is a Stampede trial showing that despite similar weight loss as sleeve gastrectomy, Roux-en-Y gastric bypass is better for diabetes. This is looking at long-term outcomes comparing diabetes with sleeve and gastric bypass. As you can see, both operations gave you good weight loss and good decrease in the HbA1c control. Similarly, looking at medication use, and this is a huge study, over 95,000 patients, 5-year follow-up, there was an increase in anti-diabetes withdrawal of medications, blood pressure medications, and statin medications. And similarly, there was a decreased reintroduction of medications for these comorbidities. This is another study looking at the relapse of diabetes, a smaller study, but 8-year follow-up. The recurrence associated with both operations was similar, but more so with diabetes, and it's dependent on the history of type 2 diabetes, not so much on weight loss, and using sleeve gastrectomy, the index operation, is also accepted. And finally, looking at the 2 randomized control studies, and what they've shown is that there's no difference in weight loss between the 2 procedures. We also had a nice presentation from Jean-Marc Chevalier on the one anastomosis gastric bypass. And then we had an overall consensus that for patients with BMI 30 to 35 with type 2 diabetes who do not achieve substantial durable weight loss and diabetes, they should qualify for metabolic and bariatric surgery. Similarly, with those with just obesity-related complications or even no related complications, metabolic and bariatric surgery was agreed to be an effective treatment. So what we found was that if you look at the choice of treatment, I'm just have this diagrammatic just showing the popularity of the 4 operations. When we looked at patients with large hiatus hernia, severe GERD, or Barrett's esophagus, what we found in our consensus of 97.5% that the Roux-en-Y gastric bypass was more favored and agreed upon than the sleeve gastrectomy. In patients with type 2 diabetes, we agreed that gastric bypass was preferable to sleeve gastrectomy, 78%. We agreed that sleeve gastrectomy is not ideal for patients with severe type 2 diabetes on insulin, 80%. We also agreed that the one anastomosis gastric bypass should not be considered as a carcinogenic procedure, 83.8%. And there was 100% consensus that with one anastomosis gastric bypass, a long limb of more than 200 centimeters is not recommended. What about patients with type 2 diabetes? Well, we agreed that Roux-en-Y gastric bypass or one anastomosis gastric bypass gives you similar results. But what about the SADI? Well, we did not reach a consensus about SADI. We asked if SADI could be an operation of choice for patients with a BMI less than 45, and we could not reach a consensus. Similarly, we asked, did SADI give a better quality of life compared to the Roux-en-Y gastric bypass? We only had a 51% consensus, which did not come into agreement. So the algorithm for patients with obesity, we summarize in this slide. We felt that metabolic and bariatric surgery should be considered in individuals with class 1 obesity who do not achieve substantial and durable weight loss or comorbidity improvement using non-surgical methods. It was agreed that preoperative endoscopy is a must to exclude severe gastric disease, esophagitis, and Barrett's esophagus, and patients with hiatus hernia plus or minus reflux could have a sleeve gastrectomy with a hiatal hernia repair or a Roux-en-Y gastric bypass. H. pylori must be evaluated before any surgery with gastric exclusions. And the popularity of operation is still remains as sleeve gastrectomy over Roux-en-Y gastric bypass, over one anastomosis gastric bypass, over SADI overall. Patients with large hiatus hernia, severe GERD, or Barrett's esophagus, a Roux-en-Y gastric bypass was more favored compared to sleeve gastrectomy. But for type 2 diabetes, one of the bypasses, either Roux-en-Y or one anastomosis gastric bypass, was accepted. Thank you very much.
Thank you very much, Lillian. Great talk. Are there comments, questions? If this is not the case, I think for the sake of time, we go further in the program, and it's my pleasure to announce Professor Ali Aminian from Cleveland Clinic to give his talk about surgical treatment of obesity, procedure choice, and algorithm for conversion or revisional surgery.
Thank you, Gerhard. Good morning, everybody. I'm going to briefly talk about this topic. We had only a few statements that we worked on conversion and revision. I'm going to briefly present those statements to you. So here is my disclosure, nothing relevant to this talk. I'm presenting the finding of consensus meeting, not my personal opinion, in the next few minutes. So in terms of definition, Dr. Salminen already showed this, but to cover the topic is going to be good to remember that we have different terms: conversion, reversal, and revision or modification. So conversional surgery means surgical or endoscopic procedures to convert to a new type of procedure. Reversal means those to reestablish normal anatomy. And we have revision or modification, which has been defined as procedures to modify or enhance the effect of previous operation. So we reached to 97% consensus on that statement. And then the second statement, modification or revision procedures are typically designed to optimize the effectiveness of previous operations, while conversion most commonly introduce additional mechanism of therapeutic action, so 95% consensus. Continue on the definitions. So these are important statements that we need to consider. Weight gain recurrence require a thorough evaluation before even considering a patient a candidate for modifying a prior procedure. So 100% consensus. Suboptimal weight loss has different implication than recurrent weight gain. So we need to differentiate these two, suboptimal weight loss with recurrent weight gain, two different phenotypes, two different implications when considering which type of intervention to consider next. So 85% consensus. And then the third one, modification of prior MBS procedure can be considered for weight issue alone, or even when pre-existing obesity-related complications are cured or in remission. So even if the comorbidities are controlled, still patient has obesity, we can consider the second operation or second intervention, so 80% consensus. Let's move on to sleeve gastrectomy specifically. So conversion surgery after sleeve gastrectomy, a general consensus that was reached 100%. GERD, suboptimal weight loss, and recurrent weight gain are the main reason for conversion after sleeve gastrectomy. Everybody agreed on that. How about the conversion surgery after sleeve for acid reflux disease? So we reached a consensus on these two statements. The best option to treat medically uncontrolled acid reflux after a sleeve is conversion to Roux-en-Y gastric bypass, 97% consensus. And then the second statement was on the assessment of acid reflux before the sleeve. So improve patient selection perioperatively for GERD risk will significantly reduce the rate of sleeve gastrectomy conversion to bypass. So 83% consensus. So good consensus on how to manage the GERD before and after sleeve gastrectomy. However, on the topic of conversion after a sleeve to tackle obesity or residual obesity, you see that we didn't reach to consensus. So let me review those three statements for you. So the first one, that we reached to consensus, in the absence of GERD symptom or Barrett esophagus, suboptimal weight loss after a sleeve can be treated by both adding anti-obesity medication or converting to the other procedure, so 87% consensus. But in terms of how to do that surgical procedure or procedure selection, we didn't reach to consensus. So the second statement explain that. So in the absence of GERD or Barrett esophagus, the most appropriate surgical option for suboptimal weight loss after sleeve gastrectomy would be conversion to gastric bypass, Roux-en-Y gastric bypass, single anastomosis gastric bypass, or DSAD. So 60% favor Roux-en-Y gastric bypass, about 20% favor SAD, 20% favored the OAGB. So we didn't reach the consensus. And the third statement, considering safety and efficacy, the most appropriate bariatric procedure for most patients with BMI over 50 and the previous sleeve gastrectomy. So we provided the options of Roux-en-Y gastric bypass, single anastomosis gastric bypass, DSAD, 61%, which didn't reach to the consensus. So although we reached a consensus on how to manage acid reflux after the sleeve gastrectomy to tackle residual obesity after the sleeve in patients who had a sleeve before. In terms of the procedure selection, we didn't reach to the consensus. How about revisional surgery after gastric bypass for residual obesity? First statement is a general topic. Revision of gastric bypass to address suboptimal weight loss would include pouch trimming, anastomotic size reduction, or limb length modification. So 78% reached to the 70% threshold to consider that as a consensus. But the second statement, we didn't reach to consensus. So, and it states that for a revisional surgery to address suboptimal weight loss after Roux-en-Y gastric bypass, given the risk of nutrition adverse event, revising the size of the pouch and simultaneously GJ anastomosis should not be done during the same operation as limb length modification, and that was not reached to consensus. Consensus was not achieved. So I have two more slides on how to manage the complications of the gastric bypass. So we had two statements on those. The first one is on how to manage hypoglycemia after the gastric bypass. And the panel agreed on that the best management, or the first management, would be treating patients with the medications. Medications such as diazoxide, acarbose, or octreotide. And the second statement on the complications of the gastric bypass was on how to manage the recurrent anastomotic or marginal ulcer. And the panel agreed that reducing the pouch size, resecting anastomosis, and creating a new anastomosis would be the best surgical treatment in management of recurrent anastomotic ulcer after a gastric bypass. Thank you very much.
Thank you, Ali, for a very succinct presentation. It is my pleasure to introduce you to our next speaker, who really doesn't need any introduction. Scott Chikora, our current president of IFSO, is going to tell you about a very challenging group of patients, patients with more severe obesity, and we call them the metabolically challenged patients. Thank you, Scott.
Thank you very much. Good morning again. I'm going to discuss the more challenging patients with greater disease burden than our typical patient. And I'm not going to tell you how we voted, because if we tell you that, no one's going to get the book. My relationships, none of any bearing on this presentation. So as you heard, this is a fairly new term, but I think it's very descriptive of the population of patients that either have excessive weight or have more disease burden than the typical patient. And the question comes up is, do we manage them similar or different than our typical BMI 40 and somebody with some GERD and hypertension? And those are questions that are not entirely answered at this time. So if you look at it, first of all, having a high weight would classify as being metabolically challenged. And obviously all of us have cared for patients with very high BMIs. And the list below it, the type 2 diabetes, the obstructive sleep apnea, et cetera, can be in a more mild form with the patient, or can be in a more serious form, or patients can have more than one comorbid condition to make them metabolically challenged. The issue comes up with, do you manage them differently? Do you do a different operation on that? And I don't think, even though we've given expert opinion, whether we really know the answer to a lot of those questions. For most of them, it's do the simplest and safest operation and live to fight another day, like do a second stage or treat with other modalities. And that would be the sleeve gastrectomy, which came across for most of these procedures as the go-to for these patients because of the safety factor. Problem is, with high BMI, you also have other conditions, such as the hypertension, the sleep apnea, et cetera. And this study here demonstrated that the higher the BMI, the more of these conditions you have, and often the more serious these conditions are. So that makes it even more challenging. One of the problems we face is that the high BMI population is increasing more rapidly around the world than class 1 or class 2 obesity, as you can see from this graph. So we are self-selecting out people who are going to be more challenging to care for down the road. Well, is there anything we can do to improve the opportunity to operate on these folks safely? One thing that's come up in the literature for decades has been a value or lack thereof of having a patient lose weight prior to surgery. And I've gone through the literature pretty well, and we can demonstrate all of those things medically, that the lungs have better function, the blood sugar is better controlled, the blood pressure better controlled, they diurese with the drop in insulin levels, reduction of the inflammatory and probiotic states. Everything you would say, if that happens, the patient should obviously do better because they can tolerate their surgery better. What about surgical? Having them lose weight surgically, number one, can it be done? That answer is definitely yes. Number two, can it be done safely? That answer is yes. Number three, aside from the fact that we can shrink the liver, we can shrink the abdominal fat, does it change outcome? And unfortunately, the answer to that is we don't know. There are papers that suggest that it does, there are other papers that suggest it doesn't, and I don't think it's been an argument that's been decided yet for either side. Venous thromboembolism, in most centers, the #1 cause of mortality. The incidence, luckily, is quite low at 0.3% for patients who have metabolic and bariatric surgery. The most common cause of morbidity and mortality in this population. They often would be, you would suggest that this population should go home on something after they're discharged from the hospital to continue the prophylaxis. Some studies have demonstrated ongoing risk for months after surgery. The problem is we really don't know what to give, which agent. We don't know how long to give it for. We don't know when it should be stopped. So yes, it's probably worth doing, but we don't have the magic formula of how to do it. Choice of operation, you just heard from Dr. Kaus some information about certain procedures, and there's no true consensus other than our consensus that one operation is clearly favorable over the other, and I think it may come down to surgeon's choice. Obesity or cardiomyopathy, another condition we don't see a lot of patients with, except if you're at a major center such as myself, And these folks can come to you quite ill from the ramifications of cardiomyopathy. And this is in addition to the fact they could have coronary artery disease, which is a separate set of conditions. This tends to be related to inflammation and body weight. And what's interesting, for every 2 to 3 milliliters per gram of adipose tissue, it increases the blood volume. And the more you increase the blood volume, the more you put these folks in congestive heart failure. And like the other conditions, it also is one of many conditions that can be ganging up on the patient at the same time. There have been studies in the literature that have demonstrated that if you can get these folks safely through surgery, the heart improves. And the most interesting aspect of this is the heart changes shape when someone has morbid obesity. The right ventricle dilates, the shape of the muscle of the septum, everything changes. And what I found to be really interesting, if they have surgery and lose significant weight, the heart remodels back into a more favorable shape. This population often ends up needing a heart transplant, but they're too ill to be touched to have a heart transplant. So bariatric surgery can be done, although at a price of it being very difficult and possibly high risk in this population, but it might save these patients from either death or from needing a heart transplant. And this is based on the Utah study, Ted Adams, a large group of patients that had Roux gastric bypass, and they were able to show the change of the shape of the heart, the reduction of insulin and lipids, improvement in myocardial function. And I'm just going to skip by this. This was just to demonstrate that bariatric surgery might be of value to this population to get them through either a heart transplant or other treatments for their cardiac failure. What about patients with LVADs? LVADs are left ventricular assist devices. It's like having an artificial heart that some of these patients need just to live because their heart is so poor in health and has very poor function. And although this is an extremely high-risk group to operate on, you can take them through surgery safely, get them to lose weight. I've had a few patients that the LVAD was removed after they lost weight and they didn't need it. And I had a few that came off the transplant list because their heart function recovered sufficiently that they didn't need to undergo heart transplant. For the sake of time, I'll go through the others quickly. Non-alcoholic fatty liver disease can lead to cirrhosis, and it's a similar story to heart failure. The sicker the liver gets, the more risky it is to do a liver transplant. And so you may want to go in between those two and have the patient undergo a bariatric procedure, get some weight off, and then see if they even need to have a liver transplant. Ditto for kidneys. A number of factors related to obesity affect kidney function, both directly and indirectly. And bariatric surgery has been shown to improve many of the conditions such you see here that are associated with kidney disease and actually promote kidney disease. I'm not going to talk about the elderly because Dr. Rahman is going to be able to speak about it better than I, and he's going to follow me. But in conclusion, metabolically challenged patients are clearly sicker, they're more difficult, they're more challenging, but if you can get them through the bariatric operation, you may actually reverse a lot of that. And the sleeve probably is a good choice for most of these patients because of its safety and simplicity. Thank you very much.
Thank you very much, Scott, for wrapping up this important topic. We might have a short discussion at the very end, so it's my pleasure to announce our next and last speaker, Professor Abdelrahman Nimeri from the US. He's our Secretary-Treasurer, and his topic will be surgical treatment of obesity, elderly and adolescents.
Thank you, Gerhard, and it's my pleasure to be here to present this data for you. This is my disclosure slide, and my financial disclosure has no relevance to the presentation. So I think for both adolescents and elderly, we wanted to know which procedures provide the best safety, efficacy, and which procedure is the most suitable for both of them. This is not the correct, okay, perfect. So this is the consensus. There were 41 experts that voted on these. For some of them, Some experts abstained because of they were like don't have enough experience. So for instance, we looked in the elderly. In individuals over 65, bariatric surgery is safe and resulted in sustained reduction in medication use and associated significant quality of life. So this was 100% consensus. Second, because the elderly individuals more than 65 are considered high risk because of age and greater metabolic disease, the safety of surgery offered, reducing postoperative complications, is of the utmost importance. So meaning procedure selection, this also reached 100% consensus. Third statement, metabolic and bariatric surgery is generally suitable for patients over 65 with class 2 obesity or higher, so BMI 35 or higher, and this also reached a consensus, 88%. Metabolic bariatric surgery is generally suitable for individuals over 65 with class 1 obesity and type 2 diabetes who do not achieve diabetes control with non-surgical measures. Again, this reached consensus, 87.8%. Generally, when it comes to procedure selection, sleeve gastrectomy is the preferred procedure for elderly over 65 because of the excellent safety profile, not the efficacy. And this also reached consensus, 75%. Older individuals are more prone to developing postoperative complications after bariatric surgery than young patients. Again, this reached consensus, 75%. The three statements for the elderly that we discussed, and they did not reach consensus, and this shows you the power of this consensus. So despite having all these experts, not everybody agreed on anything, on everything. So we talked specifically about whether older patients should be primarily offered bariatric surgery based on safety and effectiveness, meaning if someone is high risk, you don't want to offer them surgery. This was not agreed upon, but it was close to 68%. Effectiveness of metabolic bariatric surgery is reduced in the elderly. This did not reach a consensus. And considering hypoabsorptive metabolic and bariatric surgery, they're associated with higher risk and they should not be undertaken in patients over 65. This also did not reach consensus. So this is on the elderly side. When it comes to adolescents, a first statement for pediatric individuals with class 1 obesity and type 2 diabetes, metabolic and bariatric surgery is reasonable treatment option, a consensus of 85.7%. Sleeve gastrectomy should not be performed in young individuals because the procedure is irreversible. So 77.8% disagreed with that statement. And the statement is generated like this to reduce bias. Metabolic and bariatric surgery is generally suitable for individuals under the age of 18 with class 1 obesity and type 2 diabetes who do not achieve diabetes control with reasonable non-surgical methods, 76.2% consensus. Metabolic and bariatric surgery is generally suitable for individuals under the age of 18 with class 2 obesity, BMI 35 or higher, again, consensus of 73.8%. Sleeve gastrectomy is preferable to Roux-en-Y gastric bypass as the first metabolic and bariatric surgery for some pediatric patients who meet criteria for metabolic and bariatric surgery. This reached consensus 71.4%, and you must be aware of the LAPTEEN study that showed long-term that at 2 years and longer, incidence of nutritional deficiency, 2 or more or 3 or more, was higher in the teens who had Roux-en-Y gastric bypass compared to the teens who had sleeve gastrectomy. And then the final statement, pediatric patients with syndromic obesity should be considered for metabolic and bariatric surgery. A, if their BMI is more than 35 or 120%, they've had clinically obesity-related complications. B, BMI more than 40 or 140%, or C, either A or B, D or neither. So they were given the options, and the people felt both. So either BMI 35 or 40. The areas that did not reach consensus is considering hypoabsorptive procedures that they should not be undertaken in adolescents, close to but did not reach consensus, and endoscopic sleeve gastroplasty should not be an option above 12. So you heard from Christine Stier that this was actually offered. And just to conclude, I wanted to show you like what the data shows. So the data shows that metabolic and bariatric surgery is safe and effective in elderly over 65. This has been shown in the literature, level 2 evidence. Metabolic and vascular confers a longer lifespan and reduced risk of cardiovascular events in the elderly. This has been shown. Sleeve gastrectomy has lower risk, but Roux-en-Y gastric bypass has better improvement in hypertension, type 2 diabetes, high cholesterol, and reflux medication use. This has been shown as well. And also, metabolic and vascular surgery is the only proven effective method to treat severe obesity in adolescents. This has been shown already. And sleeve gastrectomy is more prevalent than Roux-en-Y gastric bypass. It has less long-term nutritional complications, and this is based on the lab teen study. So I'll stop there, and I'll be happy to answer any questions.
Thank you, Abdul Rahman, for wrapping this up. We have now 8 minutes for discussion. I'm sure there are many questions and remarks. I think it's very important to stress once more that we really tried to streamline the language we speak together with colleagues from the internal department and fields and opinion leaders in that field to be better heard, that surgery might play a more important role in the future. We have the first question, please.
Good morning. Safwan Taha from the United Arab Emirates. Thanks a lot for a very comprehensive and concise presentation of, at the same time, of this data. My question is, I think, since this is an expert opinion, I believe just to eliminate bias, I think before discussing those things, we should have had a list of the average experience of every member of the expert committee. Because when we take that and give it to the world, based on a very respected committee of 40 or 50 people, I don't know the number, but we deserve to know, the people who are giving us their experience so that we can implement it somewhere else. What was the average experience of every member of the committee? How many operations they've done in bypass or sleeve or mini bypass to be able to, I know quite a few names and I know they are extremely expert, but I think to be fair, we need to know the names of the others and their experience in performing those procedures, so to be able to give us a summary to be implemented elsewhere. Thank you very much.
Thank you very much for that question. Certainly, in a lead up to the invitation for these experts to come to this meeting, we did look up their CVs. They are experts in their area. They're all listed in this book, their institution, where they come from. Of course, it's not possible to list everything about them, and I'm sure you can look up, if you have any doubt of any one of them, they are on, you can look them up on their CV on the website. But let me assure you that these 42 experts that were invited were carefully thought through. We, of course, could invite even more, but we had to make sure that we have a range of expertise ranging from surgeons to medical experts, pediatric experts, dietitians, exercise physiologists. So we also included our integrated health experts in this consensus.
Well, congratulations for this great work and teamwork. My question is that it's more a proposal. I think that IFSO should differentiate when we talk about childhood obesity, which is quite delicate topic, that there are two different patients, very different. Children, which means from 3 to 10 years old, and young adolescents, which means till 18 years old. And if we look the papers or studies already published, most of them are focused on adolescents. We have very few data about children. So I think that we should open two windows instead of putting all together in the same box and define the indications, for example, or characteristics of children, and also a part on adolescents, which have, I think, different way of doing.
Your point's very well taken. There's a saying in card playing, you play the hand you're dealt. And if the populations out there are more heavily weighted towards adolescents than to children, At least we get data from that, and we hope in the future to have a greater number of children to study, but you can only do with what you're working with.
And it was touched in some statements. So we really differentiated between below 12 and from 12 to 18. But of course, the evidence for a lot of these things is simply not there.
Yeah, because the evidence for really young children is very, very scarce. So thank you very much.
Any other questions?
One more up there.
Reza Adib from Brisbane, Australia. Thank you very much for this amazing presentation. A lot of the elderly over 65s that we see are the survivors of the lap band era. They had a band when everyone used to throw bands in everyone. They've lived the band lifespan. Now we have to think about their revisional surgery. They can't put it just because they're 65 in the category that it's safer to do a sleeve on them. I think we just, in these conclusions, have to make some sort of a space for people with mega esophagus, poor quality of life, daily reflux, and usually not huge BMIs. I just want, if Abla Rahman could make a comment about making these tough decisions for someone who is 69, 70, terrible quality of life, and obviously not in good health.
Yeah, I think that's an excellent question. The literature before the consensus shows that when you look at Roux-en-Y gastric bypass, it produces better improvement in reflux, better improvement in type 2 diabetes, better improvement in hypertension, better improvement in high cholesterol, and less use of medications compared to sleeve gastrectomy. Now, this is not randomized trials. This is at best level 2B. But sleeve gastrectomy with the same level is safer. So at the end of the day, what's important is to have a discussion with the patient, giving them the data, and you need to know what is the patient's intention. If the patient's intention, for the most part, is safety, they should choose sleeve gastrectomy even if they have less improvement in reflux, because that's what they want. If their patient's number one incentive is to reduce their medication use, then they should use Roux-en-Y gastric bypass. And I think the data helps us until we get very solid data. We need to personalize care for high-risk patients. This is not only elderly, it's also the other patients that were presented by Scott, like metabolically challenged patients. So you could have someone with a BMI of 60 and decide to do a sleeve, and in the next patient, their BMI is 60, you decide a SADI, and the third one, you could decide a DS, based on the overall risk profile. So I think personalized care is really the way that should happen.
Thank you.
If there is no other question, I shut down this session. Please be back sharp at 11 for the presidential session. Thank you very much.
There are places that you go to and once is enough. And then there's